welcome to our KDA CPD session today on this Saturday afternoon in Kenya. It's right noon in Germany. Germany is cold. I don't know Nairobi weather, but I think it's better than here. My name is Dirk Manko, and yes, it's great to be with colleagues joining here to learn and to spend time together. Special thanks to the newly elected president of the Kenyan Dental Association, Dr. Karura Mundia, for the invitation to this event. And thank you for all the participants to have time right now on Saturday. It's weekend and everybody is looking forward to have some free time. But yes, I think we will have some good minutes right now. So, what is our topic today? I'm going to give you a practical approach to dental implantology. Because I'm a general dentist in Germany since 1992, and I placed my first dental implant in 1994. At the beginning, it was not too much because it was new. Even in Germany, there were not many people who know about implantology. At the first time, there were no courses, and I did on my own. So, but over the time, it developed something bigger. My patients or our patients took advantage of this. And you will see, perhaps you have already started with implantology. If not, try to, because you will have much more treatment options if you use these implants. If you do it on your own or if you do the prosthetic procedures, doesn't matter, but then you have someone to rely on surgery, of course. Okay, next slide. So what we see here, it's only this I want to show you. It's this graphic. You certainly know. You see in the middle, you see the titanium screw, the implant, and the surrounding bone. What is interesting here, in 1952, Professor Bronnemark has seen in his researches that the bone directly grows on this titanium surface. But I don't want to show you so many graphics because certainly you know all these things. But what I want to show you is this. Don't forget, it's always a biological process. So everything you do relies on the patient's body's healing processes, blood, general medical things. And if you do too quick or if you do too big, sometimes it will not work because the body will not accept this. And this keep in mind when you start, or it's a general thing in our discipline to respect the biological process. Okay. Today, what I want to show you is I have more than 30 years of experience in this field, placed thousands of implants and restored them too. So over time, I changed my procedures, tried to make it easier. If you come from an education, you buy new things, new scissors, new whatever. But over time, you see, you don't need so much to start with implantology, of course. What you see on this picture is my surgery, my instruments, and the implant box. I will show you later more detailed. So I said at the beginning, I'm a general practitioner. That means I do everything in my practice. Now I do even aligner. But not in the orthodontic sense. I use the line. I will show you some pictures later. And I do root canal treatments, I do fillings, everything. Most of the people come in my clinic to have nice teeth, nice smiling, etc. So when we start, then we have to have a plan. And this plan, in relation to the discipline of implantology, is a backward-driven implant planning. That means you must know, before you take your handpiece and drill a hole in the bone, you must know where to do this to give the patient later on good occlusion, good chewing, and nice looking. So implant treatment must be backward driven. So what I already said, it must be driven from the ideal prosthetic outcome. You have to talk about this with your patient, of course. What are the needs of this patient? Not everybody needs the same thing. Yeah, of course, then you can determine the position based on this restorative design. And this ensures over time, over long time, aesthetic and long-term stability. I have patients from the beginning, from the 1990s, I still have in my clinic, and these implants work. Sometimes you have to renew the crown or something like that, but it can be very successful. So I already said I use a liner, and yes, even if you think about implant treatment, you can keep in mind that a liner pre-treatment may be an option for some cases. Yeah. What can it do? It can optimize tooth position and create ideal space. So if you have crowded conditions with the teeth and perhaps space between two teeth is really small, can of course optimize this by a liner treatment. So whether this is necessary or not, enhanced soft tissue symmetry may be, but this is a complete outcome. You want to give the patient a nice smile and good symmetry, of course. Clinical benefits of this pre-treatment are you have more predictable implant axis emergence profile, what is very important for long-term stability. If the implant axis is not correct, if you have a lateral or central incisor in the upper front, it's very, very important to have the right implant axis, because otherwise, maybe after implant placement, 2 years later, the gum is has a recession, and then you see the implant. This will be a disaster for the patient, perhaps for you too. Okay, so I want to use this occasion to introduce the sponsor of this session. It's Smilodent.com. It's a company based in Nairobi. I think some of you will know them, and they offer a wide range of dental equipment like CBCT, implant system, aligner, the Smilodent aligner, and 3D printer, dental chairs, everything you want. And I know them personally. I've been to Mombasa with them some weeks ago. They are great in giving you the right equipment. And here you see one of their products, the Smilodent Invisible Aligner. I think you know better than me how to use them. Perhaps you already use them, because Guigan, one of the bosses of the company, said that you are already 36 clinics in Nairobi are using the Smilodent aligner. So these aligners came from China, from one of the biggest labs there, with over 1,000 workers, and they have big streets of machines every day producing hundreds of them. So they are very reliable, and I guess I can say it's really a good thing for smaller or even bigger orthodontic treatments, if you know how to do them, to use these aligners. So my first case here. Now you see these two pictures on the left side. I show here the slightly crowded central and lateral incisor and a fractured central incisor. So these fractured incisor, yes, we couldn't use it anymore. Even with post, it's not really reliable. So we decided to take it out and make an immediate implant there. You see it on the right side here. But then this was my fault. I didn't ask the patient clearly whether she wants perhaps aligned teeth. And then she said, okay, when I get a new tooth, perhaps we can do it better with the natural teeth. And then I said, okay, and think about it. Normally, it's better to have this in mind before even doing something, but this was an emergency almost. It was broken, and of course we had a provisional. But yeah, then we started with the liner treatment, and you can see here still the attachments on the teeth, and this left central incisor is provisional crown first we made. And after some weeks or months with this provisional crown, you see the really nice looking emergent profile here and the ceramic abutment on the right side for the definite restoration of this implant. And at the end, it was this what we see with this implant crown here. The patient did not want to correct the length of the natural tooth, so it's like more individual. But I suggested to put something on, perhaps a ceramic veneer, but she said no, she didn't want to cut this tooth for a crown. Yes, so this is what you see if you have a plan and you follow this plan. Sometimes you have you have to make new decisions, but at the end you must start with a plan in your mind. But next step, it's not it's as important as the planning, the team and the equipment. And now in Germany we have problems with to get staff members, to get assistances. I don't know how it is in Kenya, but a trained dental team familiar with all these implant procedures or other procedures with sterilization protocols, etc. It's very, very important because if you start a surgery and your surgery box is a mess, then can be really like a horror trip surgery. You're searching for every instrument on your tray and can find it. So be aware to educate your employees, your dental assistants as good as possible. It makes your working day easier. And what is necessary on the field of instruments? Yeah, like every other surgical treatment or oral surgical treatment, you need a dedicated surgical and sterilization area. No difference from other treatments, surgical treatments. And yes, of course, if you don't have, or perhaps for other surgical treatments like wisdom tooth removal, you need implant board or a surgical kit and sterile instruments. Sometimes if I do bigger procedures or the patients are very nervous, I suggest to administer conscious sedation. If you do this, you have to have yes, a small monitoring. It's not necessary like general anesthesia, but or you have someone who does it, perhaps an anesthetist, who can help you with this. Now we come to the surgical box of the implant system I use since 3 years now. Over these 30 years, I think I used over 10 different implant systems. Every system has some advantages or something you like and something you don't like. And now I use this German brand. It comes here from Berlin, where I live. It's a small surgery kit or drill tray. It's easy to use. I'm going to show you in a small video later. And of course, you see on the left side, you see this implant machine and contra angle. Okay. What I said at the beginning, you don't need that much instruments. I only use 2 forceps, scissor, 1 scissor, the waiter, something to suture, and that's not much. Sometimes, of course, you need a little bit more, like osteotomes or mallet, but for the normal procedure, it's not more than that. Perhaps still luer rongeur to cut the bone. There's too much or sharp edges. That's my standard instrumentarium. For the knife, for the blade, I use always the 50. I use nothing else. Beginner, I had something like 12 or so, but you can use this for everything. I will show you how to use it the right way later on in a small video too. Okay, this is my surgery, or was my surgery. Now I renewed it a little bit, but most of the time I don't use it in this way because it's really a lot of work to prepare everything. And for bigger procedures, okay, that's fine. You have the space, the room, and everything. But normally I do it now in a normal treatment room with these sterile fields, and of course with gowns, etc. But you don't need really a big surgery to do implants. Not necessary. So now we come to my implant system. It's a Meoplant system. You know, all these screws. Some they are different. The systems on the market are of course different. This one has in the crystal these micro threads, which is important if you have a big, compact heart, compact bone. Then these microcells will not give too much pressure on this bone, so you will not see necrosis there. But of course, you need primary stability. So in the middle part, you have a compression thread for primary stability, and the apex here, there is a part with a self-tapping thread for efficient insertion, what you will see later on in the video too. So I'm going to show you now a video from the producer, from the company. Short moment. This blunt nose is important. You cannot hurt the anatomical important structures. Oh, what I want to show you again. Wait a second. Yes, this is important. For me, it's important. A single prosthetic platform. Why is it important? You have so many pieces for an implant system. If you start, you have the implant, you have the abutments, everything, healing abutments. If you have different, even if you have only 2 different platforms, then you need, for every platform, you need more pieces. So this implant system is from 3.5 to 6.0 diameter only one platform, and this works really, really good. So continue. Yes, internal axis is important, so you have no rotation inside, and in this part you can see a conical part, so it's very stable. You need only 27, maximum 30 Newton centimeter to screw the screw, and everything is fine. That's what I already said. Regarding the stability, you can achieve high torque, but even in a hard lower jaw, if the bone is really hard, this implant can be placed very smoothly. Okay, you see again, Meoplant system. By the way, at the end, I will show you my website, implantology.com. There you can register. It's only a small one. I just started to build it. But if you register, there's a download area. You can download links to the system. You can download some forms, for example, for patient consent inform, what I use. This is in the docs format and Word format, so you can adapt it to your clinic if you want. And there are as well some clinical videos you can view after registering. Okay. This is a surgery box. You see here the wrench, parallel posts, and of course the implant drills for the different diameters. How to use it, I am going to show. On the right side, there are the insertion tools, screwdrivers, and these is on the top right. These are the depth control stops, which I'm going to show you later in the video. For the after opening, you use these two types of healing abutments. They are available in 2 diameters, and what I really like is the marking on top. The 4 marks or 5 marks, and this is the gingival height in millimeters. So if you use them, you can decide, okay, I need 3, I need ginger healing abutment with 3 marks. Really easy. For impression taking, there are 3 systems. The third I did have here is for the scanner abutments. The left one here is for the step-on technique. You screw this part on the implant. After screwing on, you place the plastic cap, and you can take the impression with a closed tray. Really easy. I use it mostly for smaller treatments like single crowns. If I have more implants or the axis of the implants are not really parallel, I use the one here on the right side. This is for the open tray. I show you in the next picture. This example for open tray. You see the long screws here. These screws will go through an individual resin tray. You open it here. You see it on the right bottom side. And to find a simple trick to find the screws easily, can put some wax over it. I have I think it's from laboratory. It's a wax for the model cast technique. I think it's slightly transparent. I put it over the holes in the tray, and then I put this is silicone material in. Put it over the implant positions, and it's easily to find the screws after the silicone hardened. So next slide. And now I'm going to show you this model surgery I prepared for you. This is, of course, a plastic lower jaw. And I'm starting with these conical triangular drill. That's my favorite, but there are other drills available. These are not standard in the surgery box. You can choose them on your own. Perhaps you have them already in your clinic. And it's only for marking the point where you start. Or you use these kind of round burr. I am going to reduce a little bit the sound of the video because it's really loud, I think. And the third one you can see here, it's I go a little bit back. It's the Lindemann burr. This is really sharp and can cut the bone on the side and on the bottom. Yes, you can use it, but it's really, really sharp and perhaps advance too quickly in the bone. After this marking, you use this implant drills from the box, and you can see these drills have marks, color-coded marks here. 2 white rings means this is a middle hard bone, and diameter is 2.9. And you can see it on the box too, the diameters and the rings, so you can adjust the diameter of the drills to the bone quality, because you always will in diameter a little bit less than the diameter of the implant, of course. So now I'll show you how to use these depth marks for safety, for your safety and patient safety. You only push the drill into this box with the needed length. In this case, it's 12.5, and you cannot advance further than these snap-on. Sometimes I want to go a little bit deeper when I know exactly, because of my planning, I have some space under my tip to the root, to the mandibular nerve. Then I go a little bit deeper, because the bone is not always equal. You can sink a little bit the shoulder of the implant under the bone if needed. Here you see the next step. It's a 3.5 drill with 2 marks. And so you advance. In this case, in this plastic bone, I'm going to place, what do I place? I think 4.8, yes. It was a 4.8. In this case, you see, I use with one mark, one blue mark, and stop. 1 means the bone is soft. It's not really soft here, but I show you why I use this one to give you an example. This is the packaging of the implants. You have any information you need, and here you can see the diameter and the length of the implant. It's a 4.8, length is 12.5 millimeter. Opening and style, of course, and you have the cap. For insertion, of course, this is very important. Even after 30 years, I'm always looking at the machine whether the speed is correct, because I almost ever use the machine in the beginning to insert the implant. It's easy and quick. You stick the insertion tool into the the implant, take it out. It's a really big one, 4.8, 12. It's big. You don't need, normally you don't need these lengths, this area, but for educational purposes, it's good. And really slowly, now at 30 or 40 revolution per minute. So now it starts. See? So because I only use one ring, what can I do now? I can put more pressure on it, more torque on it, but that's not good. Perhaps it will destroy the bone. So I have to rewind, go backward. Of course, you have to do this implant in the box again. And you see here the 2 marks, okay, to make a bigger hole. Then reuse the same implant, of course, no problem. And now it works. Take your time, don't hurry. If you use a ratchet, don't ratchet too fast. Here you can see the micro threads really clearly. For the compact bone, in this case, the bone is, and at the end I use, most of the times I use this ratchet. If you have 40 or even 50 Newton centimeter, this is not too much. This is okay, but not really more. Then I take the screwdriver, 1.4 screwdriver. Most of the parts are 1.4. Take the cover screw, which is inside the cover of the implant, and close it. So if you don't want to make an open healing, you want to, so. And this is already the gingival abutment, the healing abutment you will use after reopening. And here's the pickup abutment for impression taking, all the same. Now I hope you can hear it. This is a snap-on, but it's a really precise position so that the lab technician can use really this implant position for making a new crown. So this was the model operation, model surgery. Now we come, I don't know, the time is running. Yeah, it's really, I think I only have 60 minutes, so I want to give you an overview, but not too much slides without any content. What is really important to think about the opening technique. And this means you open and you have to close over the implant. And there are several techniques, of course. This punch, a crestal incision, triangular, trapezoidal, and periosteal releasing incision. And we start with this punch. Punch means you take your blade or even another thing to open or to cut away the soft tissue. I don't talk about this anymore because don't use it. Because soft tissue is a thing often is not enough or not good quality. And if you even take it away, you will have problems later. So please, I always open my flaps. And even if I'm use guided surgery, I don't use punch technique. So the standard incision now is the crestal incision. Of course, everybody knows along the crest. Be aware that you have good quality this attached gingiva on both sides of the incision, if possible. Sometimes in the lower jaw, after a long time without teeth, it's really small, but normally you can have this good quality gingiva. So what it shows, a direct access to the ridge and the implant side. Can see the bone, you can see whether there are still some things you haven't seen in the X-ray. Even if you use CBCT, sometimes there is a difference from the picture, or you don't exactly, is it really bone or is it a soft tissue? Yes, and of course you can create another incision if you need to see more. For example, this triangular flap, you can enhance the crestal incision if you plan a bone augmentation, for example, to both sides, of course. This is a very often used incision technique. And if you even need more, or you have to release your steel flap to cover a bigger augmentation area, can do a trapezoidal flap. I go over this a little bit quicker because I think you know some of these things, but I want to show you not only these slides with text. I'm going to show you some videos. Yeah, this is a crestal incision, of course. Have a look on how I use my thumb of the left hand to adjust my knife to have a good feeling when I cut the soft tissue. Go around a little bit to the adjacent teeth. And then I'll show you again. Yes, you can see it here. Very often I use the back of the knife to cut the connective tissue to feel the bone. That means it's not sharp, or not so sharp like the other edge, and you can use your knife longer and you have more feeling. And use a swab if you use the elevator. That can help you when you remove the or open the flap. This is an example from the lower jaw. I show you a triangular flap here. It's an augmentation case. Go around the tooth, then cut. Here we have really good conditions regarding the soft tissue. Often it's really thin, the attached gingiva, but here it's really good width. Okay, this is the vertical incision, and here's the opening for sinus lift procedure. And I think, I don't know exactly, I placed an implant in the pterygoid area, so at the really end of the maxilla. So this cut goes there, and there's often in the region of the tuber, there's often a really thick soft tissue. I like to cut because if you do later the open procedure or you make crowns, there's no space for it, so you can reduce it, use this soft tissue already while placing the implants. Same careful reflection of the flap there, using the swab. And sometimes it's really hard because of earlier inflammation. the connection from the soft tissue to the bone is very hard. You have to correct it. And then you use the swab to reflect the soft tissue, the flap, over the lateral wall of the sinus. Okay. Yeah, summary. Please match the incision to the flap design you need for augmentation or not augmentation. If possible, don't do vertical incisions because healing is easier. There are no scars laid on. The keratinized ginger, what I meant in the lower jaw, should be preserved. Yeah, tension-free closure is important if you do augmentation procedures. I show you perhaps in another webinar how to do it safely for the patient. So next step, if you have placed the implants, you need some suturing techniques. And I use only 3 techniques. These are the single interrupted, the mattress, and the continuous locking suture. And with these sutures, I use in my clinic only 3 types of needles and threads. This is the 4.40 I use every day. It's my standard needle with a super meat. I don't know whether it's available under this name in Kenya, but it's what is called a pseudo monofilament in this 4.0. Easy to make knots and very clean, very sterile if you use it. And the needle is sharp. It's a 3/8 needle. Same with the 5.0 I use for mucosa surgery. And sometimes I use a resorbable thread. This is here the polyglycolic acid material. Okay, these 3 combinations I use every day. So single interrupted, everybody knows, easy to do. Each stitch is tied separately, allows to precise wound edge adaptation. And most of the time, it's I use all these or 2 of these in one surgery. The second one is a mattress suture. It's for tension release. So if I have an augmentation and I did the pure steel releasing, then I have to close it. And first I do to adapt the flap. I use a single interrupted. After this, I use a mattress suture. There are different types. I don't tell it here. You can, or you know it already. And this improves wound stability. And what I really like, if I have to suture a longer distance, then I use a continuous locking suture. I show you in a video right now. First, we see in this video the horizontal mattress suture. This is maybe it's the surgery of the impression taking I showed you. I don't know exactly, but these are 3 implants, immediate implants, and you can see here. You can see, yes, here in this area, these are PRF membranes, platelet-rich fibrin membranes. Nowadays, I don't use it anymore. They are good for wound healing, but they take some time to prepare, and sometimes I don't have the stuff or can do it on my own. So, but yeah, in this we covered the membrane. This is PRF membrane as well. And here you see not the implant, This is already the healing abutment I put on. And I close here first with a mattress suture. And you see how nicely it adapts now. Don't pull too hard. Only adapt with feeling both flaps. Same procedure. Simple interrupted or single interrupted suture for the edges. And this is the 4.0 with this DS15 needle. Really sharp. And the filament is goes smoothly through the tissue. Okay, last but not least, the continuous locking suture. Normally, not here. If I have a releasing incision, I first do a single interrupted at the edge, and then I start with the continuous locking. With this suture, your assistants can help you. I'll show you how. So you cut the short part of the thread. Yes. And then the continuous locking suture starts. I'll show you this in my hands too, because you see how I use a needle. So this left thread is held by my assistants. Show you here, this one, this thread. Because I need a space and a good view on the tissue. And then we continue, go through both flaps, go through the loop, and pull the thread through. Okay, I hope you have seen this. And this you will continue. And look, it's really going fast here. Push it through, go through the loop. And take it, and you have the next step. So at the end, don't go through the loop. You leave the loop like that, and take the end to finish. Adjust it a little bit on both sides, and then normally I cut this myself because I had it once that the assistants cut the whole knot, and we have to restart. No, this is not the right. Okay, now we have. I hope we have still some time for the next step, planning and surgical techniques. I'm just going over this. I cannot go in detail, but I want to show you how I started. Nowadays, I use for every treatment, I use the CBCT, of course, because it's my clinic and you have more information. But when I started 30 years ago, that was not available. I started with these panoramic X-rays, and you see here the panoramic X-ray, and this is a dentulous lower jaw, and for planning I built the denture, and inside I put these wire end sleeve. It's not medical, but you see, I think they had a length of 8 millimeters, and then you could calculate the bone in the 2 dimensions, how to place them. This is, on the left, you have the planning, and on the right, the implants are already on place with the gingiva abutments. And this is how it looked inside the mouth. Are the sleeves inside, and this is surgery, after surgery. And see, I only need, but this is not guided. Don't think this is guided. I only wanted to know where the correct positions are. I couldn't take the drill inside this, and I wouldn't do this, but the outcome was good as well. And nowadays, I use my CBCT data and digital scan data. And with this software from realguide.com, I make almost all my plannings. So this is the screen of a simple planning. And this yellow here is a guide. I can print this guide in my 3D printer in my office, and I use it. And of course, if you have a bone like that, you can place the implant without a guide. But trust me, in the lower jaw, if you have the tongue and some blood, some saliva, and the cheek, sometimes it's not so good to see where to do the first drilling, and it helps very much. Then if you don't use it and you make after surgery an X-ray, and the implant could have been a little bit more distally placed, because you are looking from above, from the right side, and this is a different angle. So even if you think it's easy, if you have the possibilities to do it, do a 3D planning, and you will be fine. Okay, another planning, single tooth restoration of a second premolar. You see the sinus membrane here, and this is a 10 or 8 millimeter implant in this case. And you see the axis of the implant coming out the crown. Because most of the time, if it's possible, I try to plan my implant axis so that I can screw the crown. I want to avoid cementing whenever it's possible, because it has a lot of advantages if you can screw. You can take out it immediately. If you have problems after years, or you can to treat inflammation around the implants, of course. And you have no cement which can go underneath the soft tissue. This is a clinical pictures here with a gingiva healing abutment and emergent profile. This is not individual, of course, and you will see it in the crown, because here the crown is a little bit smaller than the adjacent teeth. If you want to have it in the palatal side, even better, you have to work with provisional crowns. But of course, all these procedures and treatments must be paid by the patient. And if you have enough time, okay, you can do it. But I think everybody wants to earn money. Give the patient good feeling and earn money. I think it's not bad. So from the outside, you can see a successful implant restoration. So guided versus freehand implantation. I think both is possible. And I personally, in my clinic, do everything with the CBCT planning, and I plan every case 3D. And almost every time I'm printing a guide. But in most of the cases, I only use it for the first drilling sequence. That means for the positioning, then I look after whether the position I planned is really good in mouth, and sometimes I adapt it clinically freehand. So for me, guided surgery is not that I'm going to use every single implant drill until I reach the correct diameter and length. Yes, of course, you have to rely on your guided system. If the CBCT is not correct, or the software is not correct, or your planning is not correct, you will have problems. Another topic is, of course, bone augmentation, because I don't know, I think in my clinic we have in 60 or 70% we need some bone augmentation, because a lot of people come to us where other doctors said, no, we cannot do it, and they come and we do these augmentation procedures. Fortunately, nowadays there are bone substitutes available we can use. We don't need to take out bone from the patient, and this is almost all the time it's particulate. Sometimes we have blood grafts, and we need membranes. I think I have a little bit time to show you only one more surgery, and then we are done for today. This is a small surgery in the lower jaw, tooth 4-6, first right molar. You can see here the X-ray. This is a CBCT, and you see the roots and the destroyed tooth. What you can see as well is inside, between the roots, there is some bone. So I've decided and explained to the patient, if it's possible, we make an immediate implantation after taking out the tooth. And you can see here slightly loss of bone. This is a mandibular canal with the English is with the nerve, I say. Okay. INA, I think, in English. Okay, first you have to take out the roots. In this case, it was easy. Sometimes you know it as well as me. Sometimes it's really difficult to take it out in this gap, but the roots weren't fixed anymore. So taking out was easy. Correct the alveole to have no soft tissue inside. And then here I didn't use template, a guide. I go inside the septum, use the different implant drills, control depths, other problems, and everything was fine. You see the pumping movements when I'm drilling. Yeah. To leave out of, or you have the cooling water. This is a 4.2 times 10 millimeter implant. And here, if I do immediate implant placement, I always screw a healing abutment on. And this is the material I use now. It's easy to use because out of a syringe called MP3 from Osteobiol. Here in this case, without any membrane. If I close the flaps, of course, I mostly use a membrane over it. So it was a good healing after that, no problems. And the X-ray. You see, the implant is a little bit below the crest, but in the buccal side, it was exactly on the level of the bone. So this will be a stable, even in the future, a stable position for this implant. One question, do I have still time to continue, or do we have to stop?
Thank you, Dr. Deho. You do have a few minutes. You can continue.
Okay.
About 10 minutes.
Okay, 10 minutes is okay. I stop at 1 p.m. then. That means Nairobi time, 3 p.m. Okay. Yes, of course. I have still something to in my presentation. Another surgery now in the upper jaw. Female, it was 2 years ago for an external sinus lift, sinus augmentation. And we used Meoplant implants as well. This is a pre-OP CBCT, and you can see really big sinus and really little of bone here in this area. The cross-section in the CBCT, and this is, I think, the region of the first molar. We only have 3 millimeters of bone. This is soft tissue here. And this is soft tissue here, and this is a crest, and lateral wall, nose, and the lower jaw. And interesting, if you see the CBCT, this recesses here in the sinus you wouldn't have seen in the panoramic X-ray, of course, because over there there's more bone. So whenever it's possible for these procedures, take advantage of the more information that delivers the CBCT scan. In this case, I decided the incision starting here behind the last tooth, so that the papilla will be stay in place, and we will not have further recession at the tooth. That you know already. Push away the soft tissue with a swab. And first time, I think, and you can see here, this is a guide, but you can see here inside, there are only a 2.1 millimeter diameter holes, or channel or sleeves, because in these cases, I use the template only for the positioning, not for drilling through with a special guided drill I also use. Okay, this is the lateral window. And if the bone over the sinus is really thick, I start with a round burr. But when I am coming close to the sinus membrane, I use this diamond burr to continue. It is a good feeling. You can feel when you touch it whether the bone is already taken off. Oh, sorry, start again. No. Yes. You have seen I push with the tip of the, or with the burr, I push on the bone, and when it moves, I see it's completely removed, and I can start preparing the lateral window with the special sinus instruments. You need to have how can I call it, a soft hand. You have to be, yes, your movements must be slightly, not hard. Then you feel the contact to the bone. You must always feel the contact to the bone, and then you can lift it easily. And if it's a sinus membrane without an inflammation, it's not difficult. It can be difficult. I have some sinus where I needed 20 or 30 minutes for this procedure here only, when there are some septa in English, or these bone needles inside the sinus. And then it can be difficult. But if you have a clear sinus, you take your time, feel it, and then prepare the sinus membrane to the palatal side completely. Then I continue with the drilling, because I know I cannot penetrate through the membrane anymore. These birds are something special. These are the Denver birds for bone condensing. And when I finished with the holes for the implants, the osteotomy, I first push some bone substitute before I place the implants, so that this bone substitute can reach the palatal side of this space. I push it through, and here, what you see here, what I already said, please be sure that the revolution is down to 30 or 40 per minute, so that you don't drill with the implant. That would be bad. The Meoplant implant, push inside. Yeah, I don't need a ratchet. I need. Okay, just a little bit, not that much. Cover screw. You see how the material comes out if you push the implant, because of course the implant itself has a volume. Some more of the bone material. Cover screw. Same procedure. In this case, I always use a membrane over this augmentation area, so that the lateral aspect of the bone can build up again. This is, yeah, you can see here the peristeel release. I do it most of the time with the back of the knife. Some kind of blunt preparation. The membrane I use, can use blood or water. First suture is a single interrupted to adapt this edge. And at the end, with some continuous sutures here, it's a good looking wound, and this is a post-op X-ray, and this is a bridge on over it. Okay, I think then I'm going to stop here. I want to show you my last slide, because there you can see the address, www.implantology.com. There you can register and can find some free material. So I am going to change my view, and here I'm again. So today it's all, but I think we will stay in contact, and if you want, we can continue learning together. It was my pleasure.
Thank you, Dr. Dick Manko, for that wonderful and scintillating presentation you've had. I believe our members have been able to appreciate the content that you have shared, and they will want to follow up on a keen interest on implantology in dentistry. Yes. Thank you so much. I don't know whether we do have a few, we could take like 2 responses, 2 questions to just appreciate and get to start on to other matters. Okay. So let me see whether there are any questions coming in from the platform. Okay, I see one. Yes, there's one. You can respond to that. I don't understand the first one. This is, please clarify, except withdrawal means Dr. Malenia. Oh, no, that's not. That one is different. Yeah, I understand. Okay, it's not for me. It's okay to do 4 mm diameter implants in the furcation region, especially immediate implants on upper molars. And please comment on the new growing of the teeth through stem cells. Oh, that's the very, very scientific question. The first one I can answer immediately. Yes, of course. 4 mm diameter maybe work, perhaps if you use at least 10 mm of length, even 4 mm diameter implants can work. In the beginning of my career, I tried to use as big as possible, 15 mm, 6 mm wide, and I just saying a little bit too much, but nowadays, if you have 4.2 for a molar, I think it will work. It will work over years. There's no need for 5 or 6 mm implants. Sometimes you need them, but my general diameters for premolar region or for incisors in the upper jaw is only 3.8, and for molars 4.2. That's enough. And for the stem cell thing, I'm looking forward to it, but I always say I'm too old. I think I will not see it anymore. So we will see. Okay, thank you. And the last question would be, there is the question from Dr. Tony Muli. He asked whether would you recommend placing a temporary crown instead of a healing collar to avoid having to mobilize more soft tissue? Yes, get a better emerging profile. Yes, if you are working in the aesthetic zone, a good question. And whenever it's possible, even the patient is paying, of course, you have to have to work a lot of time with these professional crowns, but you will have an outcome which is much better than compared if you only use the standard healing abutments. Of course, it's always a better treatment outcome. Okay, thank you. Thank you so much, Dr. Dirk Manko, for that wonderful engagement. I believe we will be following up with yourself in Vladimir and at Smiloden to keep us going on track onto the matters of professional development in implantology. Thank you so much for your time. See you next time, Dr. Munir. Thank you. Okay, bye-bye. Bye-bye. Bye-bye.